we will start.
Sure, sure.
I think so.
Dr. Pravin is not in yet, so I suppose I'll do it alone. It's just
Okay.
basically just to let people know that there is a presence, you know.
All right.
Yes, Prof. Prem.
Where are you based, Kelvin?
Typing.
Typing, all right.
Okay, so I think the participants are coming in already. So yeah. All right. Good afternoon, everyone. Welcome to our weekly webinar hosted by College of Physicians Malaysia. So our theme of the month is hematology. But before we move on to our webinar, just a few words from Associate Professor Dr. Prem Kumar, Council Member from College of Physicians.
Good afternoon, everyone. My name is Prem, and I'm a neuropsychiatrist in private practice in Penang. I'm one of the council members, and I think this is the first initiative to introduce the physicians to the council, to the College of Physicians. There's this weekly webinar that has been going on, but this is the first time we are doing this. And our president, Datuk Sri Paras Doshi, feels that it would be good if you know who the council members are. So I'm Prem. There was supposed to be Dr. Pravin, who was supposed to be here, but he might be a bit held up. So I hope you all have a good webinar. You've got a very good speaker, a good chairman, as well as a good moderator. So all the best. Take care. Thank you, Dr. Kelvin.
All right, thank you, Dr. Prem. So I'll move on. Just a few words about our chairperson today, Dr. Lau Ngee Siang. He's a consultant hematologist from Hospital Ampang. Just a few words. He obtained his MD from UKM in 1999 and MRCP in 2004. He completed his hematology fellowship training under the Ministry of Health in Hospital Ampang in 2006, and in 2008, advanced training in hematology in Townsville Hospital, Queensland, Australia. Without further ado, let us welcome Dr. Lau.
Thank you, Kevin, for your kind introduction. So it's my pleasure to introduce Dr. Christopher Liam. He's currently the consultant hematologist at Hospital Sultanah Aminah, Johor Bahru. So he graduated from the National University of Ireland in 2009 and completed his hematology fellowship training in 2021, as well as he obtained a diploma in hematology from the Royal College of Pathologists. So his topic today will be controversies in myeloproliferative neoplasm. There's something new. Hopefully, it's going to be a very entertaining lecture from him, because hopefully it's very controversial. So to keep everybody awake, clinical relevant approach. So let's welcome Dr. Christopher Liam to deliver his lecture.
Right. Thank you, Dr. Lau, for the introduction, and also thanks to the College of Physicians for inviting me to talk about MPN. Now, MPN is a topic that's full of controversies, and I think we need to alter this to a more clinically relevant approach, especially in the Malaysian setting, in light of the advancements in MPN. So, okay. So this is the outline of my presentation. So I will briefly introduce what MPN is. I'll talk about the three main types of MPN, namely PV, ET, and MF. This will be a case-based discussion. So hopefully we'll be able to share some light how we approach that case and also manage them. And if time permits, I will talk about special population groups, i.e. those with thrombotic MPNs and also those in pregnancy. And I'll summarize the whole presentation at the end. So what is MPN? So MPN is a clonal hematopoietic stem cell disorders, and is characterized by a proliferation of one or more myeloid lineages. Now, so what does this mean? It means that you obtain a mutation in the myeloid stem cells, such as the JAK2 mutation, and you subsequently have a proliferation uncontrolled by that proto-oncogene. Now, if the principal cellular proliferation involves the red cell, you get polycythemia vera. If it is a megakaryocytes, you get ET, essential thrombocythemia. And if it is a fibroblast in the bone marrow, then you get myelofibrosis. Now, in MPN, more often than not, they relatively preserve the differentiation. What I mean by this is that if you look under the microscope, a red cell of someone with polycythemia vera and a red cell for a normal person, you might not be able to differentiate between the PV and also the normal red blood cell in the normal person. Now, MPN is something that happens towards the middle age and late decades of life, and there's a clinical heterogeneity in terms of the presentation. So MPN used to encompass CML as well, but since the advent of the BCR-ABL mutation, discovery of that has broadly classified MPN into two subtypes, those with BCR-ABL positive, the CMLs, and also the BCR-ABL negatives, namely the PV, ET, MF, and the other rarer subtypes. But today, I'll be mainly focusing on the three more common subtypes, as we don't have much time to talk about the rarer subtypes. So what causes MPN? Again, that is the mutation, and there are different types of mutation that drives the process of MPN. Now, the driver mutations, the three most common are the JAK2 mutations, the calreticulin, and the MPL. Now, in PV, about 97% of them are either the JAK2 V617F mutation or the exon 12, leaving you about 3% with unknown mutations. The case is not the same for ET and also MF. So in ET and MF, you have about 60 to 80% of them with these three, what we call as a driver mutations, either the JAK2, calreticulin, or MPL, with about 15 to 30% of them are what we call as triple negative. They have mutations that are not classified as these driver mutations. So what is important is that regardless of whatever mutation that you have, whether it's the JAK2, CALR, or MPL mutations, the underlying pathogenesis of it results in the JAK-STAT activation. So when you have the JAK2 mutation, you can activate the JAK-STAT pathway directly and result in an uncontrolled proliferation. In the erythropoietin receptors, you mainly only have the JAK2 mutations. You don't get the CALR or the MPL. So in polycythemia vera, you hardly get a polycythemia vera with, say, for example, calreticulin mutations. Whereas for ET and MF, the two other commodities, then you will see some degrees of MPL and also CALR mutations, but the final pathway is still the same, resulting in the activation of the JAK-STAT. So we move on to talking about polycythemia vera, and I'd like to share a case. So case one is a 36-year-old gentleman. He's a chronic smoker for 10 years. He has presented to us with a right-sided body weakness and facial asymmetry for about 3 hours. And the evaluated NIHSS score is about 12. Clinically, there's a splenomegaly, about 3 centimeters, and the C3 brain agent showed that there's a left MCA infarct with what we call as a dense MCA sign. So we did some baseline blood investigations. The hemoglobin is raised with the corresponding hematocrit of 57. Total white and also platelet count were also raised. Now, this is what we call as a panmyelosis. The increase in the blood film, we saw an increase in red cells, but they were morphologically normal, and there were no increase in blood cells. Coagulation profile and the liver function tests were normal. So the neurology team was consulted and they opted for thrombolysis as there were no contraindications to that. And post-thrombolysis, the NIHSS score improved dramatically. So our side on hematology, we planned for a venesection 3 times per week with the aim to achieve the hematocrit of less than 45, and antiplatelet therapy has already been started by the neurology team. So a JAK2 mutation was sent, which came back much later, about 6 to 8 weeks later, was mutated, and hydroxyurea was started at 1 gram daily. And the treatment also encompassed modification of his CV risk factor, importantly cessation of smoking. So what are the presentations of polycythemia vera? So there's quite a huge range of symptoms that can be the initial presenting symptoms for a PV patient. So it can present with hyperviscosity symptoms such as headaches, dizziness. More often than not, patients will tell you that I have some pruritus, especially what we term as aquagenic pruritus. They take a hot shower and then subsequently they feel very itchy. And some of them present with erythromelalgia. So this is what it is meant by erythromelalgia. You can get a very reddish color of the hands and also the palms. And in some of the patients, they will come in with a thrombotic or bleeding event. Clinically, you might get a splenomegaly, or you might have other comorbidities caused by the polycythemia itself, such as hypertension or gout. So what is the diagnostic criteria for PV? Now, in the WHO 2022 criteria, it requires you to have three major criteria: a hemoglobin of 16.5 for men and the corresponding hematocrit of 49, or hemoglobin of 16 with corresponding hematocrit of 48 for women. Now, a bone marrow biopsy is needed to assess for the evidence of panmyelosis. Now, sometimes in the full blood count, you can already see that, but the gold standard of assessing panmyelosis is through the bone marrow. And in 97% of the time, since you got JAK2 mutation, and evidence of that mutation, either the V617F or the exon 12 mutations, more or less reaffirms the diagnosis of the PV that you are looking at. Now, in the 3% of patients whereby the mutation is negative, then you are required to look at the serum erythropoietin level, and more often than not, you will get a subnormal or a low erythropoietin level. Now, many times people will ask me, do I really need to do a bone marrow? Now, in the WHO criteria, it does mention that if you have a higher hemoglobin threshold, i.e. 18.5 for men or 16.5 for women with the corresponding hematocrit levels and a positive JAK2 mutations, you can actually omit the bone marrow assessment. Now, while it is important to diagnose PV, it is also important to exclude secondary causes. Now, I'll be mainly focusing on the acquired conditions because the congenital conditions are relatively quite rare, and more often than not, I will look for them if I have not got a secondary cause. Now, in the acquired causes of polycythemia, I can basically divide them into either it is a hypoxic driven, such as your chronic lung disease, a smoker's erythrocytosis, or even patients with OSA. So these are the patients, because of the hypoxia, the erythropoietin are elevated as a physiological response to try to compensate on the oxygen delivery. And some of the patients, especially our nephrology clinics would like to refer, is that some of the patients of kidney, such as polycystic kidney or post-renal transplant patients, will get some degree of erythrocytosis, and it is also be mindful to that. The other thing that we'll look at is whether or not there's any presence of pathologic erythropoietin production. Say, for example, any tumors like hepatocellular carcinoma or renal cell carcinoma, or if the patient is taking any medication such as erythropoietin or any androgens, which might stimulate the production of erythropoietin. So how do we manage and risk stratify for our patients of polycythemia vera? And this algorithm here has been in place for many years, right? And even to the latest NCCN guidelines, it is still the same. So for patients with PV, you will start everyone on aspirin and also to subject them to phlebotomy, venesection, to keep the hematocrit level less than 45. Now, if you have one of those risk factors of either age more than 60 years old or a prior thrombotic event, then you will require cytoreductive therapies such as hydroxyurea. Now, I've put down here highlighted in yellow the common cytoreductive therapies that are available in Malaysia. So hydroxyurea is the commonest first-line medication that we use in our clinic setting. And pegylated interferon, because of it has been used in the younger population less than 40 years old, but because of the limited availability of the stock at the moment, in our center, we tend to reserve them for pregnant patients. So we also have a certain number of patients who have already failed a first line of therapy and subsequently were started on ruxolitinib. So where does all this data came from? So to start off with the aspirin, why do we need to subject everyone to aspirin? So the data came from this trial that was published more than 10 years ago called the ECLAP study, the European collaboration of on low-dose aspirin in polycythemia vera. Now, in this study, patients were randomized into receiving aspirin versus placebo, and you can immediately see that by subjecting patients to aspirin, you reduce the risk of a thrombotic event by more than half. Now, if you do a subgroup analysis of those who really benefit from aspirin, it doesn't matter what is the duration of the disease, whether the patient is on cytoreductive therapy or not, what is the platelet count or the hematocrit, all of them benefited from the addition of aspirin. So based on this study, everyone as a blanket rule, polycythemia vera will be put on aspirin. So what about the hematocrit of 45? So the data came from this study called CYTO-PV. And in this study, it is a phase 3 study. Patients with PV were subjected to either a lower hematocrit, less than 45, or a higher hematocrit level between 45 to 50. And patients can be on aspirin, phlebotomy, with or without cytoreductive therapies. Now, in this study and in this graph, you can see here that patients with lower hematocrit has a fourfold lower in terms of a thrombotic event compared to those with a higher hematocrit level. So we have always, because of this study, kept our patients less than 45. So what about the age group? We mentioned that if the patient is more than 60 years old, then we will subject them to cytoreductive therapies. And the data actually came from this subgroup analysis of the patients who were on aspirin, and then analyze according to age and whether there's a prior thrombotic event. And you can see here, the best, of course, are the patients without a thrombotic event, younger patients. But those with either the thrombosis or age above 65, you can see that they have overlapping curves. So it means to say that the age of 65 is almost equivalent to a prior thrombotic event. Right? Of course, the ones who are the worst are those with prior thrombotic event and the elderly age group. So based on this, cytoreduction is recommended for those aged 60 and above. Now, once we start on cytoreductive therapies, there are a few things that we need to know about hydroxyurea, since it is the most common cytoreductive therapies that's been used. So there's a phenomenon called hydroxyurea resistance and intolerance. Now, resistance are whereby when you start the patients on hydroxyurea, you titrate the dose up to a maximum tolerated dose or a maximum of 2 grams per day. Now, once you have done that and your patient still requires phlebotomy or still unable to achieve that platelet or white cell count normalization, or the spleen still remains huge, then you have what we call as a hydroxyurea resistance. And in this orange and green box, we will call them as hydroxyurea intolerance if you have a cytopenias, such as ANC less than 1, hemoglobin less than 10, or the platelet less than 100. So 1, 10, and 100. So this happens regardless of how you reduce the dose. So that means to say that even if you put the patient on the lowest dose possible of hydroxyurea, say for example 500 milligram daily or alternate day, and this phenomenon still occurs, then you have what we call as the intolerance. And others would include things like GI toxicity or oral ulcers or skin cancers at any count of doses of hydroxyurea. Now, it's also important to know that in the patients where you start hydroxyurea and they have cytopenias because of that, it is a marker that the disease is rather advanced and there's a high risk of transformation to MF and AML. So what do we use for patients who are intolerant or resistant to hydroxyurea? So there's a phase 3 study called the RESPONSE study. So RESPONSE 1 is for patients for PV with splenomegaly. RESPONSE 2 are for patients PV without splenomegaly who have already have hydroxyurea and also intolerance and also resistance. So in a nutshell, so you can see here that in RESPONSE 1 and in RESPONSE 2, patients who are on ruxolitinib have achieved a better blood count control, resolution of symptoms, and also for those with splenomegaly, a splenic volume reduction. So ruxolitinib is approved for PV patients who have resistance or intolerance to hydroxyurea. So are there any other cytoreductive therapies that we use? Now, in Malaysia, we have this pegylated interferon alpha 2A. A typical dose would be 180 micrograms per week. Generally, the availability of pegylated interferon at this moment is rather limited. So in our center, we tend to reserve them for patients who are pregnant. And for the newer version of the interferon called the pegylated interferon alpha 2B, has a longer half-life, less frequent administration, but unfortunately, this medication is not available here. So just to share some info on the pegylated interferon. So row-peg interferon, the one that is not here in Malaysia, has been compared to hydroxyurea in terms of the control of blood counts and also spleen response. So what I wanted to show in this study is that, yes, it is better in terms of the control of blood count, but it is also the first study that looked into the JAK2 allele burden reduction. So patients who are on the row-peg interferon had an allele burden reduction to less than 1% in about a fifth of them. Versus hydroxyurea, we pretty much can conclude that it doesn't really reduce the JAK allele burden. Now, whether or not this translates into long-term survival outcomes remain to be seen. So there are other interesting things that is happening in the field of polycythemia vera that I would like to share with you. So before I do that, then this is a figure diagram to show you how polycythemia vera happens. So you have a mutation in the bone marrow, then you have a excess in production of red blood cells. Now that can only happen if you have got adequate iron supply to the bone marrow to produce red blood cells. Now, physiologically, in our body, we have hepcidin. It's a peptide protein that regulates the availability of iron for the bone marrow to produce red blood cells. Now, if I have a way to restrict this iron supply to the bone marrow, then I may have a way to reduce the red blood cells. So there are what we call modifiers of hepcidin. So the first of which was PTG300. The name is rusfertide. It's a hepcidin mimetic. So it functions exactly like the hepcidin. It will inhibit the ferroportin expression. Then the iron will not be able to be in the circulation for the bone marrow to be used. The other way that we can knock out the gene that expresses that inhibits the hepcidin, which is the TMPRSS gene. So if I have knocked this out, the hepcidin that is in our physiological body will be able to function normally and inhibit the ferroportin and also the excess of iron. So these are the two things that are considered the novel therapies in polycythemia vera and currently in a clinical trial at our center. So as you can see, the rusfertide being the first one, the hepcidin mimetic, patients who are on rusfertide has got a better response in terms of the cell count. They have also required less need of venesection, and they are able to sustain that hematocrit less than 45 better when you compare to standard therapies alone. So moving on to essential thrombocythemia. So I'll start off with a case again. So it's a 30-year-old lady who was initially evaluated for iron deficiency anemia with thrombocytosis. She has clinically got a mild splenomegaly. So this is already a red flag sign for you to identify that this is not just purely a IDA. So the FBC and anemia workup was performed. He has the hypochromic microcytic anemia. The normal total white and the platelet count was increased. So a blood film examination was performed. You can see those hypochromic microcytic cells and also the increase in platelet count. So true enough, the iron studies came back to be iron deficient. So when you have a thrombocytosis, it's always important to exclude secondary causes, just like how you exclude secondary causes for polycythemia. Now, common things are common. So anemia, especially like iron deficiency anemia, so we need to delve into the history what is the menstrual history like, any GI bleeding, and etc. So in clinical practice, when I exclude the secondary causes, I will almost always look for iron deficiency anemia. The second thing that I would commonly do is to send inflammatory markers such as CRP or the ESR to identify whether there's any presence of inflammatory disorders that may cause a reactive thrombocytosis. Now, do I routinely do tumor markers or subject the patients to CT scans to look for malignancies? I generally don't. Basically, it will be symptom directed. Say, for example, if the patient has got altered bowel habit, then I will subject the patient for either upper scope or lower scope. But otherwise, if the patient is asymptomatic, does not have symptoms suggestive of malignancies, I will leave it at that. So there are also other hematological disorders that can cause thrombocytosis. So for example, myelofibrosis, especially in the early stages of myelofibrosis, or polycythemia vera, as I mentioned to you, that they can have panmyelosis. So one of the cell lineage that are involved are the platelets. So you can get some degree of thrombocytosis in polycythemia vera as well. So how do we sort of like pinpoint whether this is likely to be primary or secondary? Now, if your patients have got symptoms that are related to vasomotor, then such as, for example, hyperviscosity symptoms or erythromelalgia, as what we mentioned earlier, then you're likely to be dealing with MPN rather than a reactive process. And by rule of thumb, more often than not, if the platelet count is more than 1,000, then it is suggestive of a primary thrombocytosis rather than a reactive process. So these are the clinical symptoms. I won't go through them, but just one thing to point out is that for patients with extreme thrombocytosis, they can get bleeding manifestations as they can acquire a phenomenon of acquired von Willebrand disorder. So patients, despite the paradoxical knowledge of having a high platelet count may cause thrombosis, and the other way that it can go, it can actually cause bleeding as well. So for this patient, it was treated with IV Venofer, so 200 milligram 3 times per week, followed by the oral supplementation. And it was treated for this functional uterine bleeding by the gynae team. And suffice to say that after the correction of the iron is normal, but the platelet has remained high. So this prompted the clinician to send off for a mutational analysis, and the calreticulin was detected. Now, at this point of time, we might ask ourselves, should we do a bone marrow assessment for her? Now, I've shown you that the primary thrombocytosis can be caused by a few hematological malignancies. And one of the main differential diagnoses is what we call a pre-fibrotic myelofibrosis. In the early stages of myelofibrosis, it is sometimes very difficult to distinguish between the ET and also the MF. You might not, there are some telltale signs that may tell you that this is MF, such as leukocytosis, the presence of LDH increment, but basically more often than not is you need to look into the bone marrow for evidence of fibrosis, either grade 1 or grade 0, to be able to tell the difference between ET and also MF. So for patients with thrombocytosis, ET, I'll generally counsel them for the bone marrow if they are keen for it. So how do we re-stratify patients for ET? And this is the traditional model that is actually adapted from the polycythemia vera structure. So basically, it is the same thing as well. If your patients are low risk, less than 60, with no history of thrombosis, you subject them to aspirin as per what it was shown in the ECLAP study. Or if your patient is high risk, either with the age of 60 or a history of thrombosis, then you will require low-dose aspirin plus the cytoreductive therapies. And also be mindful that if the patient got cardiovascular risk factors, you will need to be prudent to start them on low-dose aspirin as well. But as time goes by, we have discovered more mutations in the ET and MF. And one of those that first came along was calreticulin. Now, calreticulin mutated patients are a different set of patients in the ET. Now, if you can see from this graph here, the risk of thrombosis in the calreticulin mutated patients is about less than half of that of the JAK2 mutated patients. So the effect of CALR mutations are generally evident in the younger patients, but even when you look at older patients with calreticulin positive, they actually are less thrombotic compared to the JAK2 mutation patients. So because of this data, because of this discovery of the calreticulin mutation, so patients with JAK2 mutation has been given a more weightage in terms of risk stratification. So in the traditional O-risk, whereby we only subject patients for aspirin, now we can have a very low risk patients whereby the JAK2 mutations are not detected. So if you have younger age group, no thrombosis, and not calreticulin mutated patients, perhaps you may not benefit from aspirin alone. And if your patients are JAK2 mutated, then we extrapolate that information from the ECLAP study and subject the patients to aspirin. Now, in the higher risk group, we can now also divide the patients into just elderly age group. So that means you have only age 60, but without the JAK2 and without thrombosis, then maybe perhaps these patients will only need aspirin without any cytoreduction. Whereas the true high-risk patients, those with the JAK2 mutation and previous thrombosis, then you subject them to cytoreduction. So based on all this information, this is the new algorithm that is being proposed by the consensus. So very low-risk patients, that means younger age group, no thrombosis, JAK negative, you probably don't need aspirin, but you definitely do not need cytoreduction as per what it was in the conventional low risk. But in those with just the age above 60, perhaps cytoreduction has no role in these patients. Now, in the high-risk patients, then you will need cytoreductive therapies. But in terms of ET cytoreductive therapies, they do really have minimal impact in terms of symptom control. Now, the commonest cytoreduction therapies such as hydroxyurea and anagrelide, you can see here when we score the patient for symptoms, they still have some degree of symptoms even when they are on cytoreduction. So for these patients, there is a study that looked into using ruxolitinib for patients with uncontrolled symptoms with hydroxyurea, and a fraction of them will have complete resolution of symptoms, and a fraction of them will have partial resolution of symptoms. But this drug was also looked at in a larger scale of a study, comparing best available therapy in patients who are intolerant and resistant to hydroxycarbamide, which is hydroxyurea. So in this study, what they found was that true enough, they improved in terms of the disease-related symptoms, but the rates of thrombosis, the hemorrhage, and also transformation were not different when you give best available therapy versus ruxolitinib. And based on this study, ruxolitinib is not approved as a second-line treatment in ET, and you can actually consider using off-label for indication of disease-related symptoms. So which is the better cytoreductive therapies? To date, we don't have a good answer. So there is a clinical trial that looks into interferon versus anagrelide, but we have no data from this study as yet, so only time will tell. But at this moment, any choice of hydroxyurea, anagrelide, or interferon are reasonable choices. So we move on to myelofibrosis. So this is a 65-year-old man. He has abdominal distension, which is progressively enlarging for the past 1 year, associated with early satiety. He has bone pain that wakes him up at night, along with profuse sweating. And a CT scan shows a massive spleen for about 24 centimeters. So under the blood film, there was anemia, and there's what we call as a nucleated red blood cell over here. The teardrop cells, this looks like a teardrop, okay? And also the presence of a blast cells, large cells with high nuclear to cytoplasmic ratio, and also the nucleolus death. So based on these findings, there is a suspicion of myelofibrosis. Other blood investigations, the renal function and liver function were normal. B12, the folate level was normal. But over here, we found that the B12 level is markedly raised. And there is also good reason for that. So in patients with myelofibrosis or some types of the myeloproliferative neoplasms, they usually produce the inactive vitamin B12 form, so the transcobalamin 2, right, that may be falsely measured by our serum B12. So it will give you a false positive or false elevated levels of B12. So just be mindful of that. If you send a B12 level and a B12 level is ridiculously high, it may be suggestive of MPN as well. The other thing that is pointing towards the myelofibrosis is the elevated LDH level. So a bone marrow was performed based on the clinical suspicion from the blood film, and a bone marrow blast was about 2% with grade 2 to grade 3 fibrosis, and the cytogenetics were suggestive of a normal male karyotype. So here you can see the normal bone marrow, very nice, very full of normal hematopoietic cells, whereas in the fibrotic bone marrow, it is very fibrotic in the sense that there is many reticulin fibers, and there's hardly any good hematopoietic cells seen. So myelofibrosis can vary from a very early stage to an advanced stage. Now, I've shown you that the pre-fibrotic MF sometimes can be very difficult to differentiate from the ET. So they may have just only thrombocytosis. They may not have blasts, they don't have anemia, and don't have marked splenomegaly. And more often than not, the LDH levels are normal. So when you progress towards a more advanced stage of myelofibrosis, then you start getting things like, for example, anemia, a massive splenomegaly, and also the elevated LDH levels. So I've shown you the earlier slide with regards to pre-fibrotic MF, and now I'm going to show you that the advanced stage of MF, the difference being only in the terms of the degree of fibrosis, grade 2 and grade 3, and the presence of anemia, right? The others criteria in this WHO are a carbon copy of the pre-fibrotic MF. So once you have diagnosed myelofibrosis, we need to re-stratify these patients. Now, in clinical practice, I tend to use the DIPSS or the DIPSS plus score to decide whether my patients are low risk or intermediate or high risk, and etc. So I like to use these namely because that these are commonly available. We can always assess the age, the anemia, and the total white, and etc. So 1 point for each except for the anemia, whereby there's a heavier weightage for that. And the good point of having the DIPSS is that I can assess it every time the patient comes for follow-up. So it can be used at any time point, and by right, it should be used as the patients may progress from an early stage to advanced stage. Say, for example, if I see the patient today, next year he might be an advanced stage of MF, and that would determine the way I treat my patients as well. So DIPSS plus, if I have the cytogenetic information available for me, I will use the DIPSS score, and then these are the two parameters I can easily assess from my full blood count and from clinical history. Now, just to be aware that not all MF are the same, not all MF mutations are the same. So like ET as well, the calreticulin mutated patients are the best prognosis. They have a median survival of about 17 years, JAK2 and MPL positive roughly about 9 years, when those with triple negative have the lowest survival rate. Now, in the advancement of the hematological malignancies, we tend to incorporate NGS, the next generation sequencing evaluation. So some of the patients whereby they are financially capable, they are able to do the NGS, then we will look for whether there's any presence of high molecular risk mutations, such as AXXL1 and the SRSF2. Now, if you have that information, you can use a different risk scoring. Here you can see that if you have 2 mutations, then the prognosis is worse. Then you have a higher weightage in terms of the points, but the other parameters are more or less the same. So I'd like to show you how we approach myelofibrosis patients. And basically, it's somewhat similar to ET and PV as well. We we divide them into low risk or high risk. So for the high risk patients, i.e. intermediate 2 and high risk, we assess for the suitability for allogenic stem cell transplant. So if the patients are suitable for a transplant, then we will refer them to a transplant center for it to be done. Now, in the patients who are very low risk and asymptomatic, there is always an option to observe the patients without any treatment needed. Now, for patients who are symptomatic or those who are not eligible for transplant, and usually those high-risk patients will be symptomatic nevertheless, so it will be more or less directed against what symptoms that the patient has. Say, for example, if the patient has anemia, so I would like to use all these medications that can help to improve the anemia, such as, for example, steroids plus androgens like danazol, lenalidomide, if the patient has got a deletion 5q from the chromosome analysis, and also transfusion support, not forgetting that. So for spleen-related symptoms and constitutional symptoms, the first-line therapy at this point of time would be the JAK inhibitors, and the second-line options are basically what we commonly use in our clinical setting in Malaysia, such as the hydroxyurea, IMiDs such as thalidomide, and etc. So anemia in myelofibrosis is one of the most common manifestations. What we can do for patients, especially in our local setting, is to try all these medications that are available for us, such as danazol or immunomodulatory such as thalidomide. Now, when we start patients on JAK inhibitors, especially ruxolitinib or fedratinib, sometimes the anemia can worsen. But if they do worsen, it's not a contraindication for use, but it's just that we need to find measures to help improve the anemia rate and also either by one of these means here, such as erythropoietin or transfusion, or the two drugs that I've mentioned to you. So how do we assess symptom burden for myelofibrosis? Now, in clinics, usually we will use the MPN 10 score. We will also provide this sheet for the patient to bring home and do it weekly or so to see the improvement or worsening in terms of symptoms. So in terms of this, there are 10 parameters that we look at, and I've highlighted in red, yellow, and green. Basically, the yellow will be things that are suggestive of anemia, so such as fatigue, inactivity, problems with concentration. The green will be splenomegaly, such as early satiety and abdominal discomfort. And the red are mainly constitutional symptoms and also these symptoms caused by the cytokine production. So this assessment of this will give you a rough idea of how symptomatic your patients are from time to time and whether there's any improvement when you start a treatment for the patient. So just a little bit, a very short slide on JAK2 inhibitor. Ruxolitinib is the first one in class. So patients, this drug is evaluated in the Comfort 1 and Comfort 2 study, comparing placebo and also best available therapy. So in these two studies, there is an improvement in terms of spleen, in terms of symptoms, and the rate of discontinuation is less compared to the best available therapy. Now, there are other JAK inhibitors that are available in clinical study. So specifically altered according to the clinical situation that the patient has. Say, for example, for pacritinib, is mainly indicated for platelets that are less than 50. Momelotinib, if your patient has got anemia issues, and if the patient has got failed previous JAK inhibitors, then you might consider fedratinib. But all of these medications at this point of time is not approved in Malaysia as yet. So there are also other additional agents that are in clinical studies and combinations with JAK inhibitors to see whether or not they improve symptoms and also outcomes of myelofibrosis patients. So these basically, they are still ongoing studies, and I think this is something to look at when we look at the future for myelofibrosis patients. So just to confirm with Kelvin, do we have time for another 3 or 4 slides?
Yes, can. Please
Sure.
continue.
Okay.
Yeah.
Yeah. So I'll be talking a little bit about MPN in the special population, and there are two groups that I would like to address. So the first one will be patients with thrombosis, and the more commonly seen thrombosis in MPN patients are the splenic vein thrombosis. Now, how do we manage these patients? I've got a lot of questions from people, from doctors, medical officers alike, right? How to manage them, right? So for anticoagulation choice, if let's say your patient has a thrombosis in the splenic vein, then you can use actually the DOACs. Now, are there preferences for any DOACs? There isn't one, but there is one article that suggests that dabigatran may have been associated with an increased risk of recurrence. So my personal preference is to use the 10A inhibitors such as the rivaroxaban and also the apixaban. So you can also use low molecular weight heparin or warfarin in this setting. Now, what about cytoreductive therapies? Once you got a thrombosis, especially a venous thrombosis, you definitely need cytoreductive therapies. So in PV and ET, you can use hydroxyurea, interferon. For MF as well, you can actually consider using JAK inhibitors. Now, there's a special group of population which we call the MPN unclassified. So what are these people? These are the people whereby, the first presentation is the splenic vein thrombosis. They have normal blood count, but then subsequently there's some smart aleck who decided to send off the JAK mutation, and the JAK mutation is positive. So then what do you do with these patients? Do we start on cytoreductive therapies for them? So today, I don't have a good answer for you. Now, I've asked these questions to many of the experts, leading experts in the world. So it is based on the clinical scenario. So if the patient has got borderline hematocrit, say, for example, hematocrit of 43 or 44, then you might want to consider starting cytoreduction to reduce that hematocrit to about 40. So that is the current consensus. No good clinical data on that. Now, the other group that I find very challenging in terms of managing is that patients who come in with upper GI bleed, namely from the variceal bleed if they have portal vein thrombosis and portal hypertension. Now, this group of patients, you need to manage them together with your surgical colleagues or your gastroenterologist, right? Make sure that they do the scope and do the bending and manage the bleeding well. And once there is absence of stigmata of high-risk bleeding, then you might consider to initiate that anticoagulation therapy. And my advice to you is that if we initiate anticoagulation therapy for this group of patients, preferably to be done as inpatient. So the other group that I would like to address is the MPNs in pregnancy. So the MPNs in pregnancy is quite commonly seen, especially when the younger group of patients of PV and ET are within the childbearing age. Now, this is a very nice article that's been published roughly about 2 months ago by Claire Harrison, one of the leading MPN experts. So I'll just summarize what it says in this article. Number one, blanket rule for all patients, we start aspirin, and for PV patients who can't achieve that hematocrit of 45, then you need to subject them to venesection. Now, you offer low molecular weight heparin if the patient has got obstetric comorbidities, something like what you encounter in your APLS patients. So if you have unexplained miscarriages, you have early delivery, so then probably you would need to offer low molecular weight heparin in the prophylactic dose. Now, in normal population, when you assess the need for prophylactic anticoagulant therapy, you basically look at all these risk factors. So if you have 2 or 3, then you will need to start the patient on low molecular weight prophylaxis. Now, in the MPN population, you only need one of these risk factors for you to start the low molecular weight heparin. Now, what about the other patients? So if the patients who are high risk, i.e. those with a previous thrombotic event, then you would definitely need to consider giving low molecular weight heparin. So what other things that we will need if the patient is high risk previously on cytoreductive therapy? You might want to consider switching them to interferon, and post-delivery, you will continue the anticoagulation prophylaxis up to 6 weeks. and then back to the original management for their MPN as per what it was before pregnancy. So to summarize my talk, MPN is a group of heterogeneous hematological disorders characterized by abnormal mutations, such as the JAK2 and cell proliferation of the myeloid lineages. Evaluation of patients suspected of MPN requires exclusion of secondary causes, such as iron deficiency anemia, right, OSA, chronic lung disease, and etc. Bone marrow examination is important for the diagnostic and prognostication. Risk stratification is important in all the MPNs to guide our treatment decisions. Hydroxyurea is the main part of cytoreductive therapy available for us, and it's important to identify the subgroup of patients, about 20 to 30%, who are resistant or intolerant to hydroxyurea. Newer cytoreductive therapies such as JAK inhibitors or ROPEC interferon are emerging as alternatives to hydroxyurea in the front line and also after failure of hydroxyurea. Novel therapies and as monotherapy or in combination will indefinitely change the landscape of MPN treatment, and management of MPN in special population requires an individualized approach and also multidisciplinary team. So I would like to end by showing you this quote from the late Tunku Laksmana Johor. So no matter how good or bad your life is, wake up each day and be thankful. Someone somewhere out there is fighting to survive. So this is true, and it epitomizes the patients of MPN. They are really fighting to survive. So with that, I would like to conclude, and I'll be happy to take any questions.
Okay, thank you. Thank you, Christopher. All right, thank you, Christopher, for the very elaborative lecture. So I think there are few questions in the chat box. We go for first. I think we have another 7 minutes for the question and answer. So patient with chronic obstructive pulmonary disease admitted for unstable angina with the hematocrit of 55%. Any role of venous action?
Okay, so it pretty much depends on what your clinical suspicion is at that point of time. So if a patient comes in, the hematocrit is high, and you think that it is due to a secondary cause, then more often than not, there's no role for venesection or cytoreductive therapy. Now, in a setting where you can't differentiate it, right, then in the emergency setting where the patient has got a thrombotic event, then I may subject the patients for venesection until I sort out the diagnosis. Then I will decide whether there's a need for long-term venesection or not.
So in the setting of emergency, because this patient now currently having an unstable angina, do you really want to intervene with the hematocrit at 55? Because you
Yep.
still need time to wait for your
That's
JAK2
right.
result, how fast. So are you comfortable to leave it alone? But you also know that maybe you think there is likely a secondary cause because of COPD, right? So you think that hematocrit 55 is safe?
No. So most of the time, I would do a venesection perhaps once or twice and try to achieve that hematocrit of 45 while waiting for that JAK2 to be back. So I think there is no harm in taking out, as per what you do for blood donations as well. So if that patient's hemodynamically is stable, there's no low BP, is suitable for venesection, then I will err on the side of doing one. And then subsequently, once I get the result, if it's confirmed to be a PV with JAK2 mutated, then I will go ahead and continue the venesection. Say, for example, if it came back, it is negative, and the workup that we have is more suggestive of secondary, then I will stop the venesection and then manage the secondary as per what it is.
Okay, so we go for second question. If suspected MPN or MDS, but patient refuse bone marrow, any role for cytoreductive or steroid of danazol?
This is a very difficult question. So basically, more often than not, it depends on the situation as well. If let's say your patients are clinically suggestive, for example, if you have a huge spleen and the patient's LDH is high, you know, the LD the PVF, the blood film is suggestive. That's what I've shown you. There's teardrop cells, there's nucleated red blood cells. If the patient understands that, you know, without the bone marrow, we can't come to a conclusive diagnosis. This is the most likely diagnosis available, and benefit of giving medications might improve the symptoms. Then I think it's a shared decision making. But of course, I will try my utmost best to convince them of a bone marrow.
Okay, so we go for the question. All right. For the strongly suspected MPN, already rule out secondary cause, but JAK2 and CAL are negative. Any additional mutation test can be sent?
Yeah, so I think we can actually do that, but unfortunately in the Malaysian public sector setting, doing the additional mutations will incur a cost. So at this present time, we are sending to a private lab for the additional mutations. So if your patients can afford for those, I think that would be useful to send. That will help you in terms of coming to a diagnosis of the MPN. More often than not, if your patients are not able to proceed with the NGS, the next generation sequencing, so you have to come to a conclusion whether or not this patient is indeed MPN based on the morphology in the bone marrow and also your other cytogenetic abnormalities. So I guess piecing all those information together is important. But if you have the luxury of doing the NGS, that would be a good thing to do.
Okay, one more question, a bit more clinical related. In patient with secondary polycythemia, came with stroke or any thrombotic event, what is the aim of hematocrit? If the aim is 45, do we routinely reset this group of patients during the subsequent follow-up?
Yeah, so there is no good data in terms of secondary erythrocytosis. What is the good hematocrit level to achieve? Now, if your patient is indeed a secondary polycythemia, then one should actually try to establish whether we can treat the underlying cause. And if it does, then naturally the hematocrit will come down by itself. As I mentioned earlier, in the setting where the emergency and unstable angina or MI scenario earlier on, if in the sense of emergency you can't differentiate, then I don't think there's any harm to, you know, do the venesection first and then subsequently evaluate for a secondary cause. But I guess if you have established that secondary cause, say for example, if it's due to an RCC, renal cell carcinoma, then you need to treat that renal cell carcinoma, do a nephrectomy, and then subsequently it will improve. So I think there's no role for regular venesection in these patients. And certainly I don't have a target of hematocrit for them.
Okay, two more questions. How does extreme thrombocytosis lead to acquired von Willebrand disease?
Yeah, so there are actually many mechanisms in terms of acquired von Willebrand syndrome can occur. So basically in the setting of extreme thrombocytosis, so we do know that von Willebrand factor binds to platelets. So in the extreme numbers of platelet, you're actually mopping up the von Willebrand that's available in circulation. So once that is being mopped up and cleared from the circulation, you have a so-called relative deficiency of von Willebrand, and then the von Willebrand syndrome will occur and bleeding manifestations ultimately.
Okay, last question. Can we start cytoreductive therapy without bone marrow examination?
Oh, yes, we can. Yeah, so so for a lot of our PV patients, there are quite a number of them who don't have a bone marrow. Yep. So I diagnose them based on the WHO criteria that I mentioned, the very extreme hemoglobin levels, JAK2 positive, they have pan-myeloses from the full blood picture and full blood count. I start them on them even without the bone marrow result. So depending on the situation, yes, I can.
Okay, so I think we've come to the end of the session. It's very good and very informative session. And I think Chris have answered a lot of your clinical questions that you think is going to help you in the clinical scenario. But what I will say is, I think some of the MPN cases are pretty tricky and pretty complex. In those clinical scenario, you really have to refer the patients to your clinical hematologist if they have one. If not, if you are in Johor Bahru, please refer to Chris. So end my session here, then pass it back to Kevin. Kevin, do you have anything you want to inform the audience?
Yes. Okay. Thank you, Dr. Lau, for chairing the session, and Dr. Chris for the wonderful talk. And thanks everyone for joining in for the session. We will see you again next week. Thanks everyone. Goodbye.
Thanks,
Okay,
bye.
bye.